Ladies and gentlemen, you, the AGA, for this hospitality the last days, and I'm really proud to be here and thank you for the invitation. So, even if I'm the key physician of the German national team, so I will not bring you snow, but maybe hopefully a little bit lower temperature. But I will talk a little bit about of our skiing problems where we have a lot of ACL ruptures, not only in skiing but also in football. So I just want to ask you, what is the evidence for therapy in ACL ruptures in the scientific literature? Do you think it is clear? Do you think it is not clear, or maybe you cannot answer clearly because it is too difficult to answer? So I think it's just a question of perspective. The question is, do we talk about osteoarthritis after ACL? Do we talk about secondary injuries? Or do we talk about knee function? So there's a totally different ballgame when we talk about these different topics. So if you look at the sequelae of the ACL rupture, if you look at studies after 10 years, this is a systematic review, and you will see if you have an only, let's say, isolated ACL rupture, so you have a really low percentage of osteoarthritis after 10 years. You see between 0 and 13%. If we talk about combined ACL ruptures with meniscus lesion, then it is completely different. You see the osteoarthritis rate increases even within 10 years follow-up. If we talk about studies which more than 10 years, so like between 10 and 20 years follow-up, then we see if there is an untreated ACL rupture, the osteoarthritis grade increases a lot, and the ACL reconstruction, it is lower, but it's not completely zero. So anyway, if we deal the ACL rupture with treatment, conservatively, operatively, we will still fight with some osteoarthritic problems. The question is, when do we have to time the surgery? So this is a very important study demonstrating me how to work in my clinical practice. If you have a secondary lesion following ACL rupture, you have around about approximately 1% per month a risk of meniscal injury or 1% of a chondral injury secondarily to your primary ACL rupture. So around about 10% per year you have an increased risk of secondary injuries. Interestingly, if you have at the time point of the ACL injury, then you double the risk. For example, if you have a meniscus lesion, then you get a secondary chondral lesion with a double rate of 2% per month. So it is really a relevant problem. If you look at all over the critical review of the literature, right now, it is still not absolutely clear. There is no relevant differences in the development of osteoarthritis. If you look all over the literature, and the surgery is probably not an absolute prerequisite for later sports ability. So people can still do some sports. And neurophysiological sensomotor problems may comparable results in terms of function. So what is the truth? Indeed, these are all studies, and it doesn't define your personal risk. So everybody has his own individual risk, and we have to deal with that. So if somebody is more exposed, then he has a higher risk. If somebody is only sitting in the chair, there will almost no risk. So it's not really individually based. If you look at the quality of life, comparing on the left side ACL deficient, on the left side the ACL reconstruction, you will see it may be a little bit in favor for ACL deficient, so conservative treatment, but that is not true for everything. So if you look at the function after 2 and 5 years in a Cochrane library review, you see in terms of function, there is almost no big difference and relevant difference between 2 and 5 years. However, secondary surgery will appear after 2 years in almost 40% and more than 50% after 5 years. So people who live with a ruptured ACL, they have a higher chance to get secondary surgery due to meniscal and cartilage problems. So what is the difference in patients, and who will be the patients who we have to treat conservatively and operatively? So usually if somebody deal with the ACL instability, we call it copers. People who cannot compensate at all, they were calling non-copers. And people who adapt their lifestyle, they were calling adapters. So how to deal with these different people? The medical consequences would be copers, they are doing fine in their treatment and in their life. They do not probably need they will not need surgery. However, non-copers, they cannot deal with the situation, they have to go for surgery. And adapters, if they are happy with the reduced sports level, then you can wait and go for more conservative treatment. If they are unsatisfied with their situation, then you have to go for surgery. So what is the open question? Can we distinguish between copers and non-copers in the clinical setting, which is difficult? Or maybe we can also say differently, are there people where they have some kind of a healing capacity after ACL injury? So we don't know exactly really big differences between copers and non-copers, but we know that the copers, they have a better dynamic control of their body. With a pathologic tibial AP translation, they can better deal with the muscle activation, enhance quadriceps muscle activity. And the non-copers, they show they have a different kind of pattern in movement. So they have a decreased knee flexion, they have an altered hamstring recruitment, they change their behavior, moving more the hip flexion, less the knee flexion. And these are patterns where you can maybe distinguish copers and non-copers, but not at the time of injury. So when can you find these differences? Interestingly, and now it's getting confusing, if you have potential copers which are fine in the beginning after the injury, 60% of the potential copers are after 1 year true copers. So 40% are true non-copers. So a lot of people from the copers switching to the non-copers in the beginning. And interestingly, is it also possible to get from a non-coper to a coper? Here, this is a study where they show that almost half of the initially non-copers defined people are getting after 2 years to copers. So even getting from a critical situation in the beginning from non-copers, you can be getting later to a coper. So that means both sides are possible. So therefore, the decision is quite difficult, especially in the beginning, to decide who needs surgery and who does not need surgery. So decision making, let's go through. This is the list where you have to go through. You see, with a small orthopedic brain, it's hard to define because you have to think a lot of things. So you have to think about the grade of instability. You have to think about the concomitant injuries. You have to think about risk factors. You have to think about exposition in sports and profession. And you also have to think about age. But these are all parameters, and it is not complete, the list. So we still have even more to think about. So maybe I give you some information what you find in the literature maybe. So early surgical intervention, if we think all about these things, we have to get kids and adolescents with open growth plates, they need early surgical intervention because look at these meta-analysis where you see there is a clear favorite of operative treatment versus conservative treatment in terms of function over time. This is clear. It is maybe also clear when we have concomitant pathologies which need surgery, like meniscal bucket handle tear, like ramp lesions, and all these critical lesions, and maybe a traumatic cartilage loose body, which can be refilled up in the defect. These are early surgical pathologies which need surgery. And also, and this is the daily work when we work in high-level sports, we have to deal with the high exposure rate in critical sports and profession, like pivoting activities, contact sports. There we don't have to wait to see if it's working or not. But what happened after a couple of weeks, for example, we see the patient after a couple of days after the trauma, and then we will do a post-primarily surgical intervention, maybe planned after 4 to 6 weeks, and then we see after 6 weeks maybe it is completely different. So post-primarily surgical interventions, for example, when we deal first with conservative treatment and afterwards we see that the patient cannot deal with this situation, for example, he has recurrent giving way episodes, then we have to go for post-primarily surgical intervention. Or if maybe conservative treatment fails, and conservative treatment does not fail usually at 2, 3, 4 weeks. It fails usually after a couple of months when the people are getting more and more active. So always remember, clinical symptoms are changing. That means when you look in the beginning, sometimes you cannot even examine the people because they have pain. And if you look at sometimes the Lachman test after a couple of weeks, you see that sometimes the Lachman test is getting stronger and stronger. So you also have to think about these 5 essential tests to check and to really find out in the beginning and over time if the patient is clinically stable from a perspective of the doctor. So always check this. And the question is, does ACL heal? I know because this is my ACL. When I ruptured the ACL 2011, and I'm pretty sure, and I know all the doctors, they examined my knee. My knee was unstable in the beginning, but it changed over time. And after 8 months, I could restart skiing and playing soccer without any problems. And this is now 12 years ago. So even thinking about, in the beginning, having some subjectively and objectively unstable situation, it may change over time. We don't know exactly the patients who will change over time. But this is our job to find out who will be the correct patient to treat and to do the surgery. So when I come to the conclusion, so many factors involved in the decision-making process. So you see, it is not like to see the patient 5 or 10 minutes to decide surgery or not. It needs a lot of work to get your individual work in getting with the patient, to get a really individual therapy decision if you check COPA versus non-COPA. And we have also exposition in sports and in profession is one of the key factors which have to be considered. So my recommendation is, if you have a patient who want to go for conservative treatment, you have to go for conservative and functional treatment at least for 4 months, and then you may just have starting a functionally testing. So what is functionally testing, for example? This is, unfortunately the video doesn't work, but this is called a single leg hop test. Single leg hop test means that, maybe now it's not working. Okay, the single leg hop test is one of the tests in functional basis, and I'm pretty sure you cannot do this in a patient after 4 to 5 weeks after an ACL rupture. You have to wait and give him a chance to recover, and to do a rehabilitation process. So that was my last part. So thank you so much for the invitation. I'm pretty happy to hear your